Good morning, everyone. I am presenting a case of a 39-year-old female, which was referred to the IOPD from the neurophysician with severe headache, eye pain, and diminution of vision, redness, and watering since 3 days. She was a known case of epilepsy for which she was prescribed tablet Topiramate 25 milligram at night, tablet clonazepam half tablet at night, and tablet villanafixin at night since a week. At the time of examination, the patient was drowsy and was highly uncooperative at the time, and the vision could not be assessed. And the IOP, as per Goldman's applanation tonometer, was 37 mm of mercury in both the eyes, and there was periorbital edema and conjunctival chemosis. Then on a slit lamp examination, the AC was shallow and few cells were present with vertically oval mid-dilated pupils. On investigation, the USG-B scan showed choroidal thickening in both the eyes, and fundus showed hyperemic disc in both the eyes. Then, as a treatment, Topiramate was stopped after neurophysician opinion, and IV mannitol 200 ml of stat was given with eye drop prednisolone acetate 4 times a day, both eye. Eye drop atropine 1% 3 times a day in both the eyes, and eye drop trizopt 2 times in both the eyes. Then course of stay, the patient was well oriented to time, place and person, and she complained of headache, nausea, vomiting. These complaints were resolved, and IOP were measured for every third consecutive day. Then on the third day, the IOP was 16 mm of mercury and 17 mm in right and left eye respectively. Lid edema, corneal edema, AC cells were reduced, and the pupils were still dilated. She was discharged on the third day with the same drops. Then on her first follow-up, her vision was 6/18 with refractive myopia of -1 diopter spherical in both the eyes, which was improving to 6/9 with pinhole in both the eyes. Then IOP was 8 mm of Hg in both the eyes, and lid and corneal edema were reduced significantly, and AC cells were not present, and pupils were reactive at that time. Then eye drop prednisolone was tapered, and IOP lowering medication was stepped down, and atropine at a night dose was given for a month. And at 1 month follow-up, her vision and B scans were normal. Then choroidal effusion is a rare condition where the fluid gets accumulated in the suprachoroidal space. Due to the changes in the intraocular pressure and the oncotic pressure, the fluids from the choroidal capillaries move into the suprachoroidal space. It is most commonly seen after glaucoma surgery or intraocular surgeries, intraocular tumors, or drugs like topiramate, sulfa drugs like hydrochlorothiazide, idapamide, acetazolamide, sildenafil, and cannabis. Literature describes drug-induced uveal infusion, which leads to ciliary body edema, transient myopia, secondary angle closure through prostaglandin-mediated vasodilation, and increased vascular permeability. The present case demonstrates the association between the topiramate administration and the severe ocular adverse effects, including acute myopia, shallow ACs, and elevated IOP secondary to the uveal effusion and the angle closure glaucoma. Topiramate is a sulfonamide substituted monosaccharide with weak carbonic anhydrase inhibition properties. It exhibits analogous structure and physiological mechanism to other sulfonamide derivatives. The drug specifically causes forward displacement of the iris lens diaphragm due to the ciliary body swelling, which results in characteristic clinical presentation observed in the affected patients. Patients usually present as early as 7 days or as late or within 7 to 10 days after starting topiramate, and the condition resolves as we stop the medication. Of particular clinical significance is a rapid resolution of the symptoms following topiramate discontinuation in conjunction with the anti-glaucoma therapy. The literature consistently reports reversal of myopia, AC deepening, and raised IOP within days of cessation. The case highlight, the patient was referred after 3 days of onset of symptoms to the ophthalmologist, which reinforces the necessity for heightened clinical awareness amongst physicians regarding topiramate-induced adverse effects, particularly in context of acute angle closure glaucoma presentation. The take-home message: this case underscores the clinical imperative of multidisciplinary management approach with a patient with headache, nausea, vomiting, and unexplained refractory shifts to topiramate exposure history. Possibility of choroidal effusion should be kept in mind in patients presenting with bilateral acute congestive attack, especially in setting of systemic drugs.